I think we have an equally, if not more, exciting second half of the morning session. I guess when I always promote something as better or even more better, I know, bad English, in a sense, it's not meant to diminish from the morning speakers. All right, without further ado, the first of the second session speakers is Dr. Laurence McCullough, who is actually, he just told me he's 15th day enjoying retirement. Like some retired people that I know, they sometimes find that they end up working harder and longer hours than before they retired. He is a medical ethicist, and it says MD in your program and his badge, and from his CV, that is not the case. He originally did his Bachelor of Arts with honors at Williams College in Williamstown, and then his Doctor of Philosophy here at, well, not here exactly, at UT Austin. He has a very, very extensive CV. I'll try and get to the succinct meat of it. I guess he was the Dalton Tomlin Chair in Medical Ethics and Health Policy and was the Professor of Medicine and Medical Ethics at Baylor College of Medicine. What I like in academia, some of us, we put, if you have authored book chapters, he has a special section with his authored or co-authored, not book chapters, but books. So he's authored or co-authored 10 books and edited and co-edited 7 books, not chapters. He has well over 500 publications, and it was a little bit too much for me to try and sort out which were peer-reviewed, which were invited, and however, I think you get the picture that he's very well published, academic, and intellectual. Welcome.
Good morning, everyone. It's a pleasure to be here with you. It's always a pleasure to visit San Antonio. When I was a graduate student at the university up in Austin, there were 2 things that were free, which therefore fit a graduate student's budget. One was to watch our legislature when it is in action, which I recommend to you because it's simultaneously free, entertaining, and terrifying. But it's democracy at work. And the other was we would come to San Antonio and visit the zoo and pick out our professors in the various animal and exhibits. We found many of our professors in the primate house. I'll leave it to you to figure out why we did that. But one we especially found was this beautiful great bald heron in the bird section who looked just like one of our favorite professors, Charles Hartshorne. And when we told him that at the seminar the next week, he was delighted to know that because he had a lot of respect for herons. He thought they were very intelligent birds. And then he explained to us something we didn't know. He was a world-renowned ornithologist and an expert on birdsong. So here's this great scholar of the philosophy of Alfred North Whitehead, also an expert on birdsong, teaching at the university in Austin. It's one of the things that makes universities extraordinary institutions. My task this morning is to help you think carefully about the concept of quality of life and its clinical application. This is the most misunderstood concept, I think, in all of medical ethics, pediatric and adult alike, and therefore misused. And you will see me cautioning you against uncontrolled variation in the use of anything. And uncontrolled variation in ethics is poor understanding of concepts and their poor application, and that leads to poor quality patient care. And when you're applying quality of life judgments to limit life-sustaining treatment, I don't have to tell you the stakes are very, very high. I also should caution you there's not a single picture in the slides that followed. They all have words in them because that's how ethics works. We use words to express concepts. If there were fabulous pictures for some of the concepts I'm going to explain, I would certainly have that. I'm always in envy of my physician and scientific colleagues, especially our genetics colleagues, with those fabulous cartoons of genetic pathways. If only it were actually that way in reality, but that's another topic. So my objectives are to define pediatric ethics, because that's what we're going to situate all this in, using clinically relevant ethical concepts. Then the concept of quality of life, a brief history of its introduction into the ethics and medical literature and how we should properly understand it, how to apply that, and then some of the ethical challenges that come in applying this concept in clinical practice. So we need 2 ethical principles. The first is beneficence, that is on the basis of the best available evidence, physicians, other healthcare professionals should figure out which forms of clinical management on balance are going to benefit their patients clinically, and those are the ones that should be offered for consideration. And this supports the concept of medically reasonable. Something is both technically possible and expected to benefit a patient clinically. It's medically reasonable. If something is only technically possible, that doesn't make it medically reasonable, and it's not something you should offer or even consider doing just because it's technically possible. In critical care units, everybody gets themselves into preventable trouble by offering something by saying, well, we could do X. That's incomplete clinical judgment. We could do X and we think it will help your child, and here's why. Then it's medically reasonable. The next concept is respect for autonomy. By the way, beneficence is a very old ethical principle. You can find it in the ancient Hippocratic corpus. There's a rudimentary form of it in the Hippocratic Oath. Respect for autonomy comes into the history of medical ethics in the 18th century. No surprise, with the rise of democracies, one would expect that to occur. So you empower the patient or the patient's surrogate decision maker, in your case, mostly parents, with information that individuals need to make informed decisions. How do you do that? You present the medically reasonable alternatives and you describe their outcomes, that is the clinical benefits you're aiming to achieve and the risks you're hoping to avoid. You offer it or recommend it depending on the evidence. So if there's only one good way to manage a patient's condition, you recommend it. If there are multiple ways, but one has strong evidence in support of it, you recommend it. Otherwise, where the evidence is roughly equal, you offer them all and help parents or older children make choices. And then you make a reasonable effort to ascertain that the decision maker's decision is informed enough and it's voluntary, that is, it's free of controlling influence. You'll see this phrase, fully informed consent, in the literature. None of us are fully informed. That's an impossible standard to meet. You have to be adequately informed in order to make informed decisions about patient care. Next is a core concept in pediatric ethics, and this is the best interests of the child standard, and that is pediatric healthcare professionals have an ethical obligation to protect the health-related interests of children who are patients, and you have this obligation independently of the parents. It's a very important point. Your professional responsibility to your patients and pediatric care is independent of parental views and wishes. That's not to say those aren't important, but they don't play a role in the best interest standard. So this is a best interest standard, and it's unique to pediatric ethics. And following George Engel, we should understand it as a biopsychosocial concept, always keeping in mind that the evidence for the biomedical component, as a rule, is going to be stronger than that for the psychological component, which as a rule will be stronger than that for the social component. So as you go out through that concept, the evidence base tends to get weaker, which means parental authority, or the child's own authority about judgment, grows as a consequence of that. So we always be careful. Quality of life is going to be along that entire continuum. And so we have to be very, very careful in how we use that concept. So what happens is the best interest of the child standard creates an ethical obligation of all pediatric healthcare professionals to protect and promote the health-related interests of their patients. And this creates an ethical obligation of parents to do the exact same thing. So parental autonomy in decision-making is under an ethical constraint of the best interest standard, something that is not true in adult medicine. Maybe it ought to be, but it isn't. So when I make decisions with my doctors about my care, I'm not under constraint to protect the best interest of my wife. We have discussions about this, right? But that's not part of it. Maybe it should be, but it isn't. Whereas parents making a decision about the health care of their child are under the constraint of your clinical judgment about what's going to benefit their child. It's a very important aspect of the exercise of autonomy of parents. And that is why the American Academy of Pediatrics calls this parental permission rather than parental consent. That is, your job is to identify what will benefit your patients. You offer or recommend that, and parents are expected to give permission for that. Very different than you and I as adults are free to refuse that permission, even if something's very much medically or clinically in our interest. So parents are asked for informed permission rather than informed consent. This comes from a very important statement from the Academy way back in 1995, and it has stood up in the intervening 21 years now. Now, we also have to deal with the concept of what's called pediatric assent, and that is older children, usually adolescents, are capable of adult-like decisions. In many years of teaching in the clinical setting, I've learned that children, adolescent children with chronic diseases, including many of the ones that you manage, are very much mature adults about that disease and about its management. They may not be mature adults in their other aspects of their lives. For example, I remember one 15-year-old in the intensive care unit at Texas Children's, where I had the privilege to teach during my 28 years at Baylor, clutching her teddy bear while she was talking with the team about whether she wanted to be re-hospitalized for what they thought would be the terminal event of her cystic fibrosis and its attack on her lungs. And as you looked at her, you saw a 15-year-old girl. If you listened to her, you heard a young adult. She was making decisions as well as patients at the VA, where I taught for many years, were making them. And she made the decision actually not to be hospitalized during her next crisis, and that's what occurred for her. She went into hospice care and died comfortably. So older children can make adult-like decisions. Ethically, they therefore should be treated like adults. Legally, they are still under the authority of their parents. And that complication is something we're going to have to return to later on. Now we come to quality of life. So this is a phrase used with multiple meanings. As I said, I think it's the most misused, misunderstood, and therefore poorly applied concept in the clinical setting. So my goal now is to try to use the concepts I've just set out to give you a very rigorous way of thinking about this concept to avoid unmanaged variation in its use. So we all know that poor quality patient care is defined by unmanaged variation in any one of the components of patient care, and that includes the ethical component. So we want to try to be as rigorous and disciplined as we possibly can be. So here we go. So in a landmark article in 1973, Duff and Campbell were one of the first to report on the discontinuation of life-sustaining treatment of infants in neonatal intensive care units, and this was in the New England Journal of Medicine. Now remember, this was before the case of Quinlan, where the courts ruled on end-of-life treatment of adults. It was before Baby Doe in the 1980s, when the federal government became involved. This was a remarkable article, and it took a rather considerable amount of courage because they were reporting on children who died from withdrawal of treatment, including children with a poor quality of life. Now, I reread that article preparing for this lecture and reread it, looking at it, where is the concept of quality of life in this article, and it's not clearly stated. Whenever you come across an ethical concept that's not clearly stated, your alarm bell should go off, right? It's just as if someone were talking about your diagnostic nomenclature in a way that was unclear. Your clinical alarm bells go off. The previous presenter, right, did a good job of, you got to sharpen your clinical vocabulary because that is the key to conceptual clarity in clinical thinking and communicating that to parents and patients. So what did it include? It seems to include both disease-related and iatrogenic burdens on the patient. How bad? They didn't really say. You can imagine a neonatal intensive care unit what that might be. And the psychosocial burdens on parents and siblings. Now we know from children, especially who leave the hospital with special needs and who are technologically dependent, there are considerable biopsychosocial burdens on parents. Those have been documented. You've seen it, I'm sure, in the parents of the children you take who have chronic neurologic diseases and disorders. But what kind of burdens on parents and siblings? How bad? Murk, total murk, which should get you very alarmed that this is a concept not being used with much intellectual discipline. Now, I don't blame Duff and Campbell. When you're the first ones reporting on stopping life-sustaining treatment in NICUs and you're trying to explain your reasoning, we should probably expect it to be murky, because this was very early in the history of doing this. By the way, in 1973, what was a low birth weight baby? How many grams? 1,000, right? That was a small baby. When I started teaching at the neonatal intensive care unit at Scott and White Hospital up in Temple as part of the Texas A&M Medical School faculty, a low birth weight baby was 750 grams. When I went to Georgetown in 1979, they said, not here, somewhere near 600. And then the boundary seemed to be hit at around 500. So when you didn't know where the boundaries were of survivability, to make a decision to discontinue life-sustaining treatment was a very complex business. So I don't want to communicate that I'm somehow blaming Duff and Campbell. I'm simply remarking this very early occurrence sets a pattern of lack of clarity. Now, it comes into the bioethics literature in 1977 by a neonatologist named Anthony Shaw, who actually comes up with a formula. And I know doctors love formulas, but in ethics we get really nervous about them. So this is QL, quality of life, equals NE, that's natural endowment, times, parentheses, H plus S. So you all remember your algebra, right? And none of you are having seizures, and if you do, your next door neighbor will treat them for you. If you have metaphysical seizures in response to that formula, come see me, right? I will offer you ruinously expensive and ineffective treatment for it. So H is the contributions made to that individual by his home and family, and S is the contributions made to that individual by society. Now, I'm a Texan by choice and conviction, so on that formula, since S equals 0, right, for everybody in Oklahoma, their quality of life must be terrible, right? Imagine I have a good friend, by the way, who is a native Texan, who has lived in Oklahoma City for the past 15 years and assures me that he's okay. I have my doubts, right? So this is, by the way, this actually, I think, captures what Duff and Campbell were thinking, right? These various components of burdens on society, burdens on others, contributions of society, with no explanation of how this is to be done. And by the way, notice if it's contributions of society to your quality of life, then we're going to say children who come from, say, economically impoverished backgrounds have a lower quality of life just because of that, right? The looks on some faces are correct. You should get very nervous about that line of reasoning. But again, this was one of the very early formulas. Notice this is 40 years ago, trying to make sense of this. Again, it's not a matter of blame. It's that we inherit this confusion about what the concept is. It's a term that actually comes into medicine from the social sciences, and there it's used with a very precise meaning. It's engaging in valued life tasks and deriving satisfaction from doing that. So how many of you if you purchase a home, have seen quality of life studies for that neighborhood you looked in? And it's where homeowners are asked, how good are the schools? What are the parks like? How do you feel? Do you feel safe in your home? Right? Are there good playgrounds for your children? All the kinds of things that homeowners or renters want to know about, with no judgment about what level it's got to be in order to be acceptable. It's a purely descriptive account that's then left to a potential home buyer or renter to decide, do I want to live with my family in that kind of neighborhood? So it's purely descriptive. There is no preconception of what life tasks are worth engaging in. Right? So here was my vivid experience with someone deciding for me what my quality of life should be. The night before I graduated from Williams with a degree in art history and a functional minor in music and philosophy, my father, who was a hard-nosed businessman, said, so now what are you going to do? Right? And it turns out I wound up teaching doctors, which he never quite understood what that meant. He wanted all of his children to be doctors, as many children of the Depression did. Because those are the only people who had decent livings during the Depression. Everybody else was in real trouble. But he thought, and then when I, by the way, decided to go to graduate school in philosophy at the University of Texas, he thought I had lost my mind, because he's a provincial New Englander, was a provincial New Englander, right? New Jersey, just the thought of it would cause him to become very anxious. And Iowa was like, it bordered on China. I mean, it was very far away. So no preconception of what life tasks are worth engaging in, although I can tell you if you want to know what the best life task is, and that is, as a scholar of the history of medical ethics, it's going to libraries in the United Kingdom, working with old books written by great doctors in the history of medical ethics, and doing this with your wife, who in my case is an historian, and it's called being an archive jock. By the way, that describes both men and women. So that's the highest quality of life you can possibly have. Correct? You are all deeply misguided. You think being a doctor is a high quality of life. By the way, you're right about that. It's a wonderful life. Nor any preconception of how much satisfaction you need to derive from your quality of life, and it's patient-centered. Notice, no contribution no component of what others are contributing to your quality of life or burdens you're placing on them. That's not part of the concept. You focus on the patient. And that's what we're going to do from here on out. So we're going to use this concept. You're engaging in life tasks. You can get satisfaction from them, and it's focused on the patient and no one else. Now, what do we know about this in the literature? There's agreement that the most reliable perspective from which to make quality of life judgments is from the patients. So you have to ask patients what their quality of life is. And if you're asking children, that's a challenge because they may lack the maturity to have settled on valued life tasks and to get satisfaction from them. If you had told me as a provincial New Englander growing up in Needham, Massachusetts, that I was going to wind up living in Texas and loving it and teaching ethics to doctors, I would have looked at you like you had just beamed in from Iowa or even someplace further away that was strange, like Alaska, right? So it's the patient's perspective, not someone else's. So making judgments for someone else about their quality of life is perilous business. And LaPlage and Hunt, in a beautiful paper in 1997, I think it's in JAMA, showed that when you compared self-reported quality of life of patients with major diseases and disabilities and their doctor's assessment of their quality of life, the doctors consistently come in lower. That is, they're underestimating the quality of life of their patients. Now, why is that? My hypothesis is we who live by our heads and our hands, right? Philosophers just live by their heads. Imagine ourselves in a circumstance where we can't do that very much, and that must be an awful quality of life. So we put ourselves in the place of the patient, we remember exactly who we are and say, wow, look at that change, I wouldn't want that in my life. That's my hypothesis about how we do that, and you have to resist that tendency. So you folks especially, making quality of life judgments for your patients is perilous business if you do it from your perspective. So one take home already is don't do that. Do it always from the patient's perspective, and we got to figure out how that's going to go. Next, Segal and Tyson, in a beautiful review of quality of life studies of children, report that having an anatomic and physiologic loss that results in functional impairment does not automatically result in self-reported lost quality of life. And in fact, in some of the studies where they had children without diseases or disabilities and compared to children with diseases or disabilities, there was no difference in self-reported quality of life in the two groups. Now, what does one make of that? The remarkable capacity of our species to adapt might be it. When you can do some things, but only in a limited range, you can still do some things, and you can find satisfaction in that. It's a very complex critter we're talking about in terms of the human critter. So again, another caution about trying to make quality of life judgments simply based on functional status. So proxy judgments of quality of life of individuals with functional impairments are not as reliable as self-reported, which is going to become a challenge because younger children, that's not going to be. With older children, adolescents, we're going to see that does play a role. And so judgments of healthcare professionals about the quality of life with individuals with functional impairment are not as reliable as self-reported quality of life. So notice how we're trying to get more and more disciplined in how we use this concept. So how do we invoke it? This is especially going to focus on using quality of life to set limits on life-sustaining treatment. So it is in the best interest of all pediatric patients to survive when they have at least some quality of life, whatever it is. Now, why? Why have I come to this judgment? It's because invoking poor quality of life as perceived by others is a dead end. It can't get you anything reliable. So this is a deliberately conservative approach. As long as the patient has some interactive capacity, and therefore some capacity for quality of life, it's in the interest of that child in terms of quality of life to continue to survive. There might be other reasons we would invoke. We could talk about those during the question and answer period, but our focus here is on quality of life. So this is a very conservative, small c, conservative concept. Why? Because the previous analysis forces us to this. So the way ethics works is you go where argument takes you. And if the only way you can clarify a concept is to wind up in a very conservative understanding of it clinically, then that's what you do. You simply follow the argument where it takes us. Now, we have two populations of patients we now want to look at with that general admonition in mind. So let's first of all, younger patients not able to make adult-like decisions. So a crucial distinction, a poor quality of life as determined by others As I've tried now to emphasize, this is at risk for uncontrolled variation and is therefore poor quality clinical ethical judgment, so you can't use poor quality of life as perceived by others. That is out of your thinking and it's out of your discourse with parents. Instead, the question is, has the child's condition eliminated the capacity for any quality of life? That's not poor quality of life, that's no capacity for even a minimal quality of life. So when a child has a diagnosis that meets that condition, especially neurologically, so when the patient no longer has the capacity to interact with others or with his or her environment, the patient no longer has the capacity for any quality of life. Don't say poor quality of life. No capacity for any quality of life. What does that mean? Is the interest in survival has come to an end, and the beneficence-based obligation to continue life-sustaining treatment has come to an end and is therefore no longer medically reasonable, even though in many cases it's going to remain technologically possible. I mean, modern pediatric intensive care units, in which I've taught for many years, are amazing places, as our neonatal intensive care unit. Now, it's very important to understand that this account rejects vitalism. Vitalism is the view that human life is valuable even if it has no interactive capacity associated with it. You cannot find this as a value anywhere in the history of medical ethics, anywhere in the world. Now, how can I say that with such confidence? One of the books that your colleague mentioned is called The Cambridge World History of Medical Ethics, which I co-edited with a wonderful colleague and friend, Robert Baker, we had 55 scholars from 27 countries chronicling the history of medical ethics in all global cultures, from the ancient times to the end of the 20th century. In reading and rereading all those chapters and editing them for publication, I kept looking for a vitalist tradition somewhere and sometime in the history of medical ethics. It's not there. And that's because physicians have recognized from ancient times that there are limits, justified limits, on what you do for patients, even though the patient is just alive. You have a phrase for this, by the way, in the clinical setting. It's a little harsh, but it's things like, this patient is just a physiologic preparation. I even heard the phrase laboratory preparation over the years. It's a way of saying this is a functional, physiologically functional human being, but that's all. There's no neurologic function. There's no interactive capacity at all. So this is not vitalist. Some of your parents may be. And this becomes a very important point of disagreement that has to be managed with great respect, sensitivity, and care by recommending that the parents seriously think about stopping. Many of these parents come from religious traditions that are very young. They tend to be Protestant traditions, except for a very old one, Orthodox Judaism tends to be a vitalist tradition. And setting limits based with parents coming from those faith traditions is a real challenge. But the ethics of medicine is not vitalist and never has been. Now, if a child meets this condition, has irreversibly lost interactive capacity, that child will meet the definition of an irreversible condition in our Advanced Directives Act, which has 3 components. You can't cure or eliminate the condition. It will leave a child not able to care for self or make decisions in the future for a child. And if you discontinue life-sustaining treatment, the condition is fatal. And it might even fit a definition of a terminal condition. The death is expected in 6 months, even if life-sustaining treatment is continued. That's a judgment of the attending physician. If the attending physician thinks one or both of those definitions apply, it is also legally permissible to discontinue life-sustaining treatment, and you must follow your hospital's policy at that point. So your hospital will have a policy for implementing end-of-life decisions, and you follow it. If your hospital has an ethics consult service, they can help you with that. Risk management can sometimes help with that. So it's ethically permissible in these cases to discontinue life-sustaining treatment because the best interest of the child standard is not being violated. Why? Because when you've lost interactive capacity, it's not in your interest to continue to live from a clinical perspective. From a theological perspective, you might get a very different account. And the disease-related or iatrogenic burdens may not result in harm because when your interactive capacity has been eliminated, you tend to have lost awareness. And if you can't experience those burdens, it's hard to say in what sense treatment is burdensome on a patient who has lost all awareness. Now, there is another limiting condition that was put into literature by Richard McCormick in 1974, I knew Dick well. Dick was a Roman Catholic Jesuit theologian. He and I were colleagues at the Kennedy Institute of Ethics at Georgetown University when I was there in the 1980s. And he had a landmark article called To Save or Let Die in JAMA in 1974, based on a case in Maine of a young child with multiple anomalies. And his argument is that the interest of a pediatric patient in survival reaches justified limits when disease-related and iatrogenic burden of morbidity, lost functional status, pain, distress, and suffering irreversibly overwhelm what little interactive capacity the child would otherwise be able to express. And he says when disease has overwhelmed the child and the disease eliminates the interactive capacity that's still there, then the beneficence-based obligation to continue has come to an end. So you can see clinically very conservative, very narrowly circumscribed justifications. And again, this rejects vitalism as well. And again, the definitions of a terminally irreversible condition may apply in the attending physician's judgment. That may be you. And again, follow your hospital's organizational policy for discontinuing life-sustaining treatment when the provisions of our Advanced Directives Act apply. So again, it's again ethically permissible to offer discontinuation. If there's some rudimentary awareness still there and the child seems to be suffering, then recommending discontinuation of life-sustaining treatment becomes appropriate. I think with modern palliative care, that's going to be a rare event, I think. Am I right to say that? In which case, recommending discontinuation of treatment, but offering and explaining to parents that they can love their child and agree with you that it's time to stop is, I think, the concept they need to hear. I learned that from a brilliant pediatric intensivist, Fernando Stein, at Texas Children's Hospital. Those of you from TCH know him. I had the pleasure of teaching with him there for 28 years. He also tells really bad puns that cause brain disorders that neurologists not only can't diagnose, they can't treat, and they're metaphysical as well, and I can't treat them either. That's how bad they are. But I love Fernando very, very dearly, as does everybody who knows him and has the privilege to work with him. So those are two conditions. Now, what's the clinical ethical challenge for you guys is to map your diagnoses onto those two categories. So which neurologic diagnoses would tell us with confidence that the patient's condition has eliminated the capacity for any quality of life? Now, permanent vegetative state would surely be a paradigm example of this, but perhaps not the only one. Second one's going to be more challenging. Which neurologic conditions combined with physical conditions are going to overwhelm the interactive capacity of the child? And the burden of proof is on applying these conservative readings of the concept of quality of life to children who lack the capacity to make decisions for themselves. How do you manage uncertainty? Life-sustaining treatment continues with careful observation of whether you're trending toward either irreversible loss of interactive capacity or what little capacity there remains being irreversibly overwhelmed. When that trend gets clearer and stronger, then it's time to sit with the parents and say, we need to think about setting limits. Parents, especially if you explain to them that critical care is a trial of intervention, and that we're undertaking it because we expect and hope that will help their child, but if that turns out not to be the case, we'll be talking to you about setting limits. Having that conversation early in the course of treatment allows you to have these conversations later, because you can remind the parents, and you say, unfortunately, no one's happy when the limits of medicine have been reached to sustain any patient's life, especially the life of a child. Okay, how about adolescents capable of adult-like decisions? So if quality of life can be applied and should be applied from a patient's perspective, and if some adolescents are capable of adult-like judgments generally, then they might be capable of adult-like judgments about an acceptable quality of life for them. I was introduced to this in the pediatric intensive care unit at Georgetown, where I taught in the 1980s, by two patients whom I'll never forget. One was a young man who had lost his left leg above the knee to osteosarcoma, and he now had a remission and metastatic cancer throughout his body, basically. And his parents told the team, he's gone through enough, it's time to stop. This was like the Monday, or this was like the Friday of the week before Thanksgiving that year. And the attending, because the concept of pediatric assent was in the pediatric ethics literature, At that time, the Academy had not endorsed it, but a man named Sandy Lycan, chief of HEMONC at Children's Hospital in Washington, had introduced it just across town. And so the attending said, I think we need to talk to your son, is that okay? And they said, sure. And he said, I'll put up with this, because if you can get me home to spend Thanksgiving Day at the dinner table with my family, that's how I want them to remember me before I die. This is a 16-year-old. I remember when I was 16, I couldn't have done that, right? But with respect to his cancer, and it was the voice of a young adult. So with respect to his cancer, he was a mature young adult. And so his parents authorized a round of phase 1 experimental chemotherapy, which kept him alive to get home for Thanksgiving Day. He got home, he came back into the hospital and died the next morning with his family all there with him. But his quality of life was to be remembered that way by his parents. The other was a young woman whose body was failing her from cancer. The treatment was overwhelming her, and she said to the team, I can't bear this anymore. I need this to stop. And her mother said, no, you've got to go on. And the team sat down with her and said, we want you to listen to your daughter. That's all we want you to do. And they asked her questions, and she explained her reasoning again. You could hear the voice of a young, mature adult making a quality of life judgment, which her parents came to accept. And then that was cleared with the hospital council, and her parents authorized discontinuation of the cancer care, and she died very comfortably in the hospital. So the interest of an adolescent patient capable of adult-like decision-making and survival comes to an end when the patient has a neurologic or other condition, the functional status of which the patient judges for himself or herself to have an unacceptable quality of life. And they do that in a thoughtful and deliberative way, just as we would expect and want any adult patient to do. If the patient refuses life-sustaining treatment, then ethically, the assent-based obligation to continue life-sustaining treatment no longer exists. It's no longer in the patient's interest from the patient's perspective, right? There's still some quality of life there, but it's not acceptable to the patients. That's an autonomy-based invocation of the concept. Again, it's rejecting vitalism, and parents retain the legal authority to make this decision. So this is an area where ethically you're getting permission, but the law has to be followed. And so I put this in red. Without exception in cases like this, you must follow the organizational policy. Why do I say that? There are 2 readings of the Texas Advanced Directives Act. One is it's the only way to let someone die in Texas. The other is it's the only way to let someone die in Texas and get the immunities that the statute provides. On that second reading, since the definitions of a terminal irreversible condition might not apply, the organization might take the view we're not going to risk letting a child die without those immunities. That's a prudent and reasonable position for a hospital's leadership to take. They could also say, yes, we're prepared to manage those risks. But that's up to the leadership of the hospital. So you must consult with organizational policy to make sure. If the policy does not permit continuation of life-sustaining treatment, then you explain that to the patient and to the parents, and that it does not allow you to recommend or offer discontinuation of life-sustaining treatment. You then identify and recommend clinical interventions to protect and perhaps improve the functional status and therefore quality of life of the patient. The patient then, if survives and comes up to the age of 18, then you have an adult refusing life-sustaining treatment. The Texas Advanced Directives Act is irrelevant. All adults can refuse life-sustaining treatment, whether they have a terminal irreversible condition or not. Or the patient may progress to having a terminally irreversible condition, and then you have the legal permission under the statute to set limits. If the organization does permit parents to authorize discontinuation, then discuss this with parents and the patient following pediatric assent, especially if the child's judgment is that it's time to stop. You want the parents to sit with you and listen to their child. Most parents, I think, when they hear what their child says and how seriously it's being said by their child, will come around to support their child. I think it must be the hardest thing in the world as a parent to recognize you can love a child and accept that it's time to stop life-sustaining treatment, and they'll need lots of support from everybody on the team to get to that. And then you implement the informed permission of the parents who have final legal authority. But I can't emphasize enough in these cases, without exception, please do follow your organization's policy because none of us are free to put the organizations that we work for at risk legally without their knowledge and permission. Here are the references that I've relied on in this presentation, and I'll be glad in our remaining time now to see what questions you have, especially any clinical cases that have vexed you currently or in the past that we can think through together.
Any questions? Please come on up. Tell us who you are. Well, whilst you're working out the thought and the courage of coming up here, if you will, let me try and phrase this. So whether you, first of all, thank you, Dr. McCullough, for a very informative and entertaining lecture. You're probably, I guess most ethicists may be anti-vitalists, even if you haven't thought about it that way. Is your personal and professional thought, so the opposite, I'm probably that way as well, as I think many neurologists are. I'm thinking about the opposite side of the coin when you've talked about cognition is everything, intellectual ability. So spinal muscular atrophy disease, which is, not to insult you, it's, if you're not super familiar with it, I'm sure you are, anterior horn cell disorder, where often the intellectual disability is preserved or normal. Right. Does that make you much more personally and professionally extreme, if you will, on that side, all about sustaining life at all costs because they have normal intellectual? Does my question make sense?
Yes, yeah, but I wouldn't characterize it as sustaining life at all costs. You're sustaining life at what is an acceptable cost because there is intact neurologic function and all those interactive capacities are there. I think you're raising one of the hardest questions, I think, in all of pediatric ethics, that diagnosis. And so you could still, the question is, when they don't have at birth, they're not going to have a terminal condition, which means you would expect death to occur within 6 months, even if you gave life-sustaining treatment. So it wouldn't apply, right?
Well, I think we're able to keep them physiologically alive for a lot longer with tracheostomies and
right, but remember, the Advanced Directives Act says you expect death to occur within 6 months, even if you give life-sustaining treatment, right? So our Advanced Directives Act is crafted in that same small c conservative fashion. And so when I've had these discussions at the bedside, I ask the attending, do you think this child has a terminal condition? Here's the definition. The answer comes back, no, not yet. Well, when? Who knows? A long time from now? Is that a fair, right? The future, this is uncertain. The next thing you'd ask is the condition an irreversible condition? You can't cure or eliminate it. Is that true? Yep. Will it leave this child in the future not able to care for herself or make her own decisions? It's an either or. Well, yes, they'll have the ability to make decisions, but they won't have the ability to care for themselves. And if you don't treat it, is it fatal? That is, you expect death to occur very quickly, and the answer is yes. So it looks like, with respect to the ability to make decisions, it's an irreversible condition, but the child's cognitively intact. And then silence falls over the healthcare team, which I take to be diagnostic. This is a really hard one ethically, right? And Zeke Emanuel, who's chief of the ethics group at the University of Pennsylvania, says when we have hard ethical cases, we should devote hard thinking to them. What does hard thinking tell us? If you can't justify with confidence stopping the treatment, then don't stop it. Number one. Number two, don't charge ahead and stop thinking. You got to keep thinking, right? So what sort of trial of intervention with life-sustaining treatment is appropriate for these children, for what length of time, and at what times do we stop and evaluate where we are and what the trends are, and ask, do these definitions apply? That would be in other words, you're managing enormous uncertainty, but the definition of irreversible condition seems to apply, but normally when it applies in children, they both lack the decision-making capacity and the self-care capacity. That is, the neurological damage to their brain is so extensive, both are lost. But with this diagnosis, it's one, but the statute is clear, either loss of decision-making capacity or loss of self-care. So I think it's one where it fits. If the parents were inclined to agree that life-sustaining treatment should be stopped, I think you'd want to get an ethics consultant. I think you'd want to have risk management. You want to get everybody on board with that, so that remember, risk managers are placed on this earth by God to help us manage risk, not to tell us how to manage risk, right? The way you manage risk is making really good clinical ethical judgments and then asking the risk managers to manage the residual risk. Now, that's not me speaking. When I was at Georgetown, the in-house counsel was a lawyer named Julie Adelson, and Julie was a shark. She was an impressive shark. She had mouths all up and down her body filled with multiple sharp teeth, but they were sharp teeth there for us, so we felt very good about that. But she would sit there in these neonatal ethics consults and say, don't ask me what to do. You won't like the answer. Tell me what you think you should do in good professional, clinical, and ethical judgment, and I'll defend it. That's what she needed. So you need your best clinical ethical judgment that then puts you in a position to defend what you did. So you've raised a really hard, I think one of the hardest diagnoses in all of pediatric ethics to try to get our arms around. So you don't stop thinking and you proceed very cautiously. I'm not sure if that's a satisfying answer, but hard cases tend to leave us with unsatisfying answers. But you guys are neurologists. You're used to that, right? This is not a room full of surgeons. Other questions or comments? All righty, well, thank you very much.
We are about 10 minutes ahead of schedule. I won't lock the doors, but don't leave. If you could, maybe if you want to stand up and stretch for about 2-3 minutes while I meet the next speaker. We'll start in literally about 5 minutes. So.